next talk is entitled Association Between Prophylactic Antibiotics and Risk of Early Infectious Complications After Pediatric Central Venous Access, presented by Dr. Stephen Papastefan.
All right, thank you. Infectious complications after central venous access device placement can result in the need for device removal, interruptions in life-saving chemotherapy, and life-threatening sequelae such as septic shock. Many children with malignancy are immunocompromised and therefore at significantly higher risk of infection. While prophylactic antibiotics are generally not indicated for wound class 1 operations, there's a lack of consensus for cases involving implanted prosthetics or for high-risk groups such as immunocompromised patients. Still, multiple medical organizations, including the CDC and the American Society of Clinical Oncology, recommend against routine antibiotic prophylaxis for long-term central venous access device placement. However, these recommendations are based on highly heterogeneous adult literature, and there's truly minimal evidence to guide recommendations in children. Thus, our aim was to evaluate the impact of prophylactic antibiotics on infectious complications after central venous access device placement in children with cancer. This was a retrospective cohort study using the Pediatric Health Information System database. We began by identifying children aged 1 to 18 with malignancy between the years of 2017 and 2021. Patients were divided into 2 cohorts according to the procedure that they underwent, either port or tunnel line placement. The primary outcome of this study was early infectious complications, which was a composite outcome of central line-associated bloodstream infection, bacteremia, and SSI within 14 days of the procedure. We excluded any patients who had antibiotics on the day prior to the procedure in multiple malignancy categories, who underwent a VAD insertion other than their first, and had a port and tunnel line within the same encounter. In total, we had 15,762 patients who were eligible, and after exclusion, there were 9,216 patients included in this study, with 6,058 ports and 3,158 tunnel lines. Patients were then classified as either receiving no antibiotics, prophylactic antibiotics with less than 24 hours used as a proxy, or extended antibiotics, or greater than 24 hours. Patients were additionally subcategorized based on malignancy type. This chart shows that there were intergroup differences in device types used. In patients with ALL, CNS tumors, lymphoma, and solid tumors, ports were used in the majority of cases, whereas for AML patients, tunnel lines were predominantly used. In our overall cohort, prophylactic antibiotics were used in 57% of cases, no antibiotics in 34%, and extended antibiotics in 10%. Prophylactic antibiotics were associated with a significant reduction in early infectious complications compared to no antibiotics, with 1.3% for prophylactic antibiotics compared to 2.4% with no antibiotics. This effect was not seen in ports, however, you can see the low baseline rate of early infections. In tunnel lines, there was a significant reduction in infection with prophylactic antibiotics, with 3.7% of patients receiving prophylactic antibiotics developing early infections compared to 6.3% with no antibiotics. This graph similarly shows the difference in early infectious complications between ports, where no difference was seen, and tunnel lines, where prophylactic antibiotics resulted in a significant reduction in early infectious complications. Again, it's important to note the low baseline rate of infection in ports compared to tunneled lines, where a difference is more apparent. Factors that were associated with early infectious complications on multivariable logistic regression included tunneled lines and AML, while solid tumors and prophylactic antibiotics were associated with reduced risk. Finally, we looked at the utilization practices across FIS hospitals, with each individual hospital on the x-axis and on the y-axis antibiotic utilization percentages. You can see the significant variability in practice, with some hospitals on the left administering prophylactic antibiotics for almost all patients, and on the right prescribing them for minimal to no cases. So in conclusion, we found that prophylactic antibiotics are associated with reduced rates of early infectious complications, though this effect is primarily driven by tunnel lines. This was the largest study to date performed in children and allowed us to look at utilization rates across hospitals, which are highly variable. Therefore, despite multiple national organizations recommending against prophylactic antibiotics for central venous access devices, Our findings suggest a benefit in children with cancer, and we urge hesitance in uniformly applying these national recommendations to pediatric practice. Thank you, and I'm happy to take any questions.
Nigel Hall, Southampton, UK. Thank you for this. I think it's an important study distinguishing between adults and children and the challenges of drawing conclusions from one population to another. I want to get into the detail a bit more, that you may not have the answers based on your methodology, but what do you mean by prophylactic antibiotics? Type of antibiotics, timing and related to procedure, and when they're given upfront versus down the catheter after it's been placed? And secondly, delving into your outcomes a bit more, there's a difference between a systemic central line-associated infection and a local site-based infection. Do you have individual data on those parts of your composite outcome?
Yes, thank you for the question. So we first defined our antibiotic strategy. They were all parenteral antibiotics, so not flushing through. And we just did antibiotics, and that's really, kind of one of the limitations is we're not able to say whether this was, preoperative ANSEF or whatever. In terms of the timing, we can't actually parse that out based on this database. So we use 24 hours as a proxy, acknowledging that that might be, 3 doses of perioperative ANSEF in some cases. It might be a dose of vancomycin, or it might just be a dose of preoperative ANSEF. So, it's something that we can't necessarily say with this. Actually, looking at the differences between central line-associated bloodstream infection, bacteremia, and SSI, we did find a reduction in each of those individual groups as well, but we decided to combine them for the purposes of this presentation into a composite outcome.
Hi, thank you for your talk. Barry Rich from Cohen Children's in New York. Were you able to look at the neutropenic status of the patients, or if they were currently receiving treatment or prior to therapy? Thank you.
No, thank you. But that is something that we definitely thought of. We were not able to look at that. I looked into the literature in terms of what's available or what's out there regarding neutropenic status, and there is a study that was published in 2021 that actually looked at that for AML patients in particular, and they didn't find a difference in terms of infection for patients who were neutropenic at baseline at the time of placement, but that study did not look into prophylactic antibiotics or anything like that. This study was designed to kind of assess feasibility of a randomized control trial, and I think looking at the numbers that we have, I don't know that we'll be able to do that necessarily, but I think that some of those aspects would have been interesting to look at.
I think we have time for one more question.
Brendan Campbell, Hartford, Connecticut. Thanks for that interesting study. I would just provide one word of caution about using administrative data to draw conclusions to change practice. I love the idea of a randomized control trial to sort of guide this, but as you know, administrative data is often inaccurate and can sometimes cloud what the true findings are.
Yeah, thank you for your comment.
Thank you.